On behalf of the Provider Relations team at the University of Iowa Hospitals and Clinics, we thank you for attending today's presentation, Atrial Fibrillation Updates at the University of Iowa Hospitals and Clinics, with Dr. Troy Rhodes, cardiac electrophysiologist. Our faculty's goal is to share information you can use about the latest therapies and techniques in medicine and answer your questions about how to partner with us in the care of your patients. If you would like more information or to talk with Dr. Rhodes following this presentation, please reach out to your provider relations liaison or directly to him through his contact information. These are informational presentations to enhance your clinical practices and to provide you the most updated information we have. No CME credit is provided at this time. This program is being recorded and will be posted to our educational resources for referring physicians webpage. At this time, I'll turn it over to Dr. Rhodes, and thank you for presenting today.
All right, and thank you for this opportunity. What I'll be talking about today is an update on atrial fibrillation. I'm a cardiac electrophysiologist, so I'm an electrician, not a plumber. So everything with my practice is focused on arrhythmias, cardiac devices. So what we're going to talk about today is an update on atrial fibrillation. Most of the talk that will be focused upon the 2019 update on the American ACC Heart Rhythm Society AFib Guidelines. We're going to talk about the risk of stroke with AF, the role of anticoagulation in stroke prevention, and then we're also going to talk about pharmacologic and non-pharmacologic options for AF management. No specific disclosures for this talk, but I do serve on a business strategy advisory board for Boston Scientific. So most of my talk will be based on the 2019 update for management of patients with AF. That is a joint publication between ACC, American Heart Association, and the Heart Rhythm Society. Unfortunately, we're beginning to see more patients with AF, and as the years progress, we're going to see more and more patients with AF. A lot of my practice focus on patients with AF, and unfortunately, this is the most common arrhythmia worldwide, and as the years progress, we'll be seeing more patients with AF. One of the things that we try to get the fellows to do when they're presenting patients with AF is to classify the type of AF. And that really comes down to the duration that the patient has been in atrial fibrillation. A patient with early AF may be paroxysmal, in which their episodes will terminate spontaneously or with an intervention such as a cardioversion or a medication within 7 days of onset. As their AFib progresses, we then begin to have persistent AF, where they are in continuous AF for greater than 7 days. With much more severe long-standing AF, they progress to long-standing persistent, which is continuous AF of greater than 12 months. Patients who are deemed permanent AF, at that point, it's typically a joint decision by the patient and their clinician to cease further attempts to restore or maintain sinus rhythm. So these are patients who have had, for example, whether it be long-standing persistent AF, they've had multiple cardioversions, they've had multiple antiarrhythmic drugs, they've had multiple ablations, and we just, cannot get them into and keep them in sinus rhythm. We'll then deem them permanent. Now, one of the, there's within the types of AF, there is valvular AF, and that is AF that is occurring in the presence of rheumatic mitral stenosis, a mechanical bioprosthetic heart valve, or a mitral valve repair. In the 2019 update, they actually removed the term non-valvular AF. So we really, will no longer use the non-valvular term. Getting back to the classifications, another P that I try to explain to patients is that AF is progressive. Unfortunately, this week's paroxysmal AF patient can be next week's persistent. So, with aging, we just see the progression of AF. Okay. When it comes to AF management, one of the things that I try to teach the fellows to address first is anticoagulation, because to pursue a rhythm control approach where we're going to do a procedure, give them a medication to, convert them from AF into sinus rhythm and try to keep them in sinus rhythm, we can only really do that if the patient's appropriately anticoagulated. For patients, who we see that are acutely ill, they're having a pneumonia, they're having a GI bleed, and we're seeing them, on the inpatient side for AF management. A lot of those patients cannot be anticoagulated. So we're really, basically, the decision is we're going to rate control that patient because we're not able to anticoagulate. So at least, from a management standpoint, there's two arms of treatment for the, for the rhythm itself, but we really have to think about anticoagulation first, because many times that decides, what our next steps are. So as many of you know, there is, it's a considerable, risk of stroke with AF. There's a 5-fold increased risk with AF. AF-related strokes tend to be more severe than non-AF strokes. With mitral stenosis, there's a 20-fold increased risk of stroke. And one thing that, we have to catch ourselves is, a patient, we tend to feel better because, oh, it's paroxysmal AFib, it's brief, but, that paroxysmal patient has the same stroke risk as persistent, which is why, as we talk about the anticoagulation, their classification of AF really doesn't come into the decision to be anticoagulated. Okay, and typically, the majority of strokes that occur with AF occur due to thromboemboli that originate from the left atrial appendage. So the left atrial appendage is this outpouching. Now this is a TE image, so we're actually looking at the left atrium. We're looking at that left atrial appendage outpouching, and due to the atrial stunning that occurs in the setting of atrial fibrillation, atrial flutter, you lose the contractility of the left atrial appendage, the blood pools, a clot forms. Okay, which is one of the reasons why in people who have AF of unknown duration, who haven't been anticoagulated, we'll do a transesophageal echocardiogram prior to the procedure to make sure that no clot is there. Okay, so one thing that comes up, commonly in with neurology and in cardiology is, cryptogenic stroke. Someone who's had a stroke of unknown etiology, they've had a full evaluation, they've had their carotid Dopplers, they've had their, transthoracic echo, they've had an event monitor looking for AF, we haven't seen it, but unfortunately, as we follow these patients longer, AF is seen commonly in patients after cryptogenic stroke. And one of the things that they mention in, the most recent update is that in patients who have had a negative evaluation, they've had a negative event monitor, we haven't seen an AFib in the setting of 30 days of continuous ambulatory monitoring. Implantation of a cardiac monitor and what we refer to as a loop recorder is reasonable for the detection of subclinical AF. So not uncommonly in these patients who have risk factors for AFib in terms of they may be hypertensive, they may be diabetic, they may have LVH, we will, see AF as we follow them longer. So what a loop recorder does is it's a small recording device. One of the earliest loop recorders was made by Medtronic. Earlier loop monitors were about the size of a USB drive, so they were fairly sizable, but they were implanted under the skin, typically over the left chest, and they would monitor and give you a single lead EKG continuously to monitor for AF. Now, with technology, things are getting smaller, and now this is the current loop recorder, which is the Link, which is actually injectable. So I make a small incision in the 4th to 5th intercostal space, and then I use this tool. I basically tunnel it in to create a tract, and then the device is actually injected under the skin, and then put a small suture buried under the skin to seal it. And this monitor lasts 3.5 years, but it continuously monitors for AFib. So this is one of my patients who had a cryptogenic stroke, had risk factors for AF. Their 30-day event monitor, was negative, and not too long after the loop recorder, I get a remote transmission, in the clinic that the patient, we're now seeing, AF. Patient was asymptomatic. This was the most likely cause of their cryptogenic stroke. and the patient was started on metoprolol for suppression and also rate control, because even at rest, I mean, he was having heart rates, close to and above 100, and he was started on, novel oral anticoagulant for stroke prevention. So when it comes to if you see a patient with cryptogenic stroke, they've had an event monitor that's negative, by guidelines, the next step would be a referral to your friendly EP for consideration, of a loop monitor. So a lot of the management, a lot of the discussion with AF really comes to anticoagulation. So the earlier guidelines, before the 2014, used the CHAD score. The 2014 update really changed that to the CHADS VAS score for the assessment of stroke risk. The reason for that is it better discriminated the stroke risk among patients who had a lower CHADS-2 score, and it really more clearly defined anticoagulation recommendations. So, one of the, basically an app that I use, almost, daily in clinic, as we're having these anticoagulation discussions with patients with AF, is the American College of Cardiology's AnticoagEvaluator. So it builds on the CHADS-2 score. So it looks at, do they have heart failure? Do they have hypertension? What's their age? Do they have diabetes? Have they had a prior TIA or stroke at any time in the past? It then builds on the VAS component, which looks at, do they have a history of vascular disease? It better discriminates with age in terms of it gives you a 65 to 74. Then it also looks at female gender, as a risk factor for stroke. The other reason I like it is because it also gives me a bleeding score. So it builds on, the CHADS-2 VAS score, but also allows me to plug in to look at their bleeding score as we talk about the risk benefits of anticoagulation for that patient. One thing that did change, with the recent guidelines is that female sex, if it's the only risk factor, does not confer a CHADS-2 VAS score of 1. Female sex does add to the score when another risk factor is present. So, for example, if age is a risk factor, if they have hypertension, you then would combine that with female sex to calculate their CHADS-2 VAS score. If we look at, one thing that they did recommend is that I mentioned earlier, is that the type of AFib really doesn't matter. We feel better because, it's a paroxysmal patient, and I've even catch myself saying it, their episodes are short, they're, a couple hours, but, when you're looking at their risk of stroke and you're trying to make a decision with anticoagulation, it's really based on their risk factors for stroke, irrespective of their AF of whether their AF is paroxysmal, persistent, or permanent. And the other thing is with the guidelines, atrial flutter is treated the same as AF when it comes to stroke prevention. So one of the things that was updated is that for patients with AF that have, at least in men, have 2 or higher for their CHADS-2 VAS score, or 3 in women, oral anticoagulation is recommended. One thing that they did change was that they're now favoring the novel agents, and that, and that includes Pradaxa, Xarelto, Eliquis, and Endoxaban. They're now favored over Coumadin, except for patients with moderate to severe MS or who've had a prior mitral valve repair. So the other thing that they kind of updated was that, renal and hepatic function should be tested prior to starting a novel agent and at least annually thereafter. In patients who have, in men who are 2 or higher, and women 3 or higher, who have, severe renal insufficiency or on hemodialysis, it's reasonable to use warfarin or apixaban for oral anticoagulation. Those are the 2 preferred agents for that patient population. And we see that, and then in patients who have undergone, have had a stent placed, who unfortunately, in many cases, they're initially on triple therapy with aspirin, Plavix, and then also a blood thinner for their AF, double therapy with Plavix and with either low dose Xarelto or lower dose Pradaxa or dabigatran is reasonable to reduce the risk of bleeding as opposed to triple therapy. In patients who have, who have a very low score in terms of 0 for men, 1 in women, which is just female gender, it is reasonable to, omit antithrombotic therapy. We feel better because the patient's on aspirin, but aspirin's never really been proven to have a benefit. In patients who have have a score of 1 in men or 2 in women, anticoagulation, may be considered. Since I have a lot of patients with AF, I tend to be pretty conservative. So, and so I, tend to have discussions about stroke risk, especially in a lower risk patient population such as this. Now, unfortunately, despite increasing risk of stroke with higher CHA2DS2 VAS score, what we really see is that oral anticoagulation peaks at about 50%. And unfortunately, despite patients having a much higher risk of stroke, we really don't see a much higher utilization of oral anticoagulation. And a lot of that really, in some of those patients is due to, despite their higher risk of stroke, they have a much higher risk of having a bleeding event with anticoagulation. So as we look at, anticoagulation, unfortunately, it peaks at about 50%. A lot of this, this was older data, so a lot of the patients were predominantly on Coumadin at the time. Now, despite the emergence of the novel anticoagulants, anticoagulation adherence remains a challenge. 30% of patients who are on a novel agent have tended to stop the drug at 2 years, whether that's due to a bleeding issue or a cost issue. So we see, at Coumadin, we're seeing about 50%, and unfortunately about 30% at 2 years, even on the novel agents. So, unfortunately, we have a lot of patients who have a higher risk of stroke and need to be anticoagulated, but unfortunately are not able to. And a lot of times that's due to either a bleeding issue or a fall issue that, that basically the risk of having a bleeding event unfortunately outweighs the benefit of anticoagulation. So a non-pharmacologic device that has been developed allows us to seal or close the left atrial appendage. And one of the devices that I implant here is the Watchman device. It's indicated to reduce the risk of thromboembolism from the left atrial appendage in patients with AF who have an increased CHA2DS2 VAS score, who we would recommend anticoagulation based on their risk of stroke, but have a contraindication to long-term anticoagulation. And typically we see GI bleeding, we see refractory hematuria. I have a number of patients I've implanted, just because they've had debilitating falls and just can't be safely anticoagulated due to their fall risk. So the Watchman device, it's a catheter-based procedure. It's all done from a femoral vein approach. We do them with anesthesia because during the procedure, we do it with, we implant the device with TE guidance, but with a single IV via a transeptal approach, I can basically put in a Watchman device that, basically seals the appendage. We typically have the patient anticoagulated for 45 days post-implant. At 45 days, we do a follow-up TE to make sure that the device is well seated, that there's no leak around the device, and that the appendage is sealed. And then we can start de-escalating their anticoagulation. We can get them off their Coumadin, get them off their novel agent. We typically will have them on aspirin and Plavix for 6 months from implant, and then at the 6-month mark, they stop their Plavix and go just on aspirin. So it is a good alternative that has been proven to be equivalent to, Coumadin, but does not expose them to the risk of bleeding with an anticoagulant. The device is permanent. Once it's in, basically it's there to stay. So this is, what we see by TE during one of my implants. So we have by TE, we look at the appendage. We have the Watchman device, basically in the appendage. This is the guide catheter, and then this is basically the cable that secures it as we're basically implanting it and make sure that we're happy with the position before we release it. And then this is an X-ray of or fluoro picture of an implant before we released it. So what the Watchman device has been shown to do is it leads to a 55% reduction in disabling and fatal strokes. It leads to a 72% reduction in major bleeding because patients are able to come off of their anticoagulants, and there is actually a 27% reduction in all-cause mortality. So it is a good alternative for patients who unfortunately have a high CHA2DS2-VASc score, have a high risk of stroke, may have had a stroke previously, but due to their bleeding risk are unable to be anticoagulated long term. You know, this is an option for these patients. So we're kind of going to shift now from anticoagulation into kind of true what for right now rhythm control, when we're basically going to convert people from from AFib and back into sinus rhythm, whether that's by a cardioversion, an ablation, or an antiarrhythmic drug. Anticoagulation is important, because if we can't anticoagulate, we really can't pursue a rhythm control procedure safely. The reason for that is atrial stunning. Due to the AFib, the atrium, the left atrial appendage is stunned. That stunning or loss of contractility can occur even within 1 hour of atrial fibrillation. If the duration is less than 2 weeks, typically the ability of the left atrium and appendage to contract will return within 24 hours to a week. With episodes over 2 weeks, that stunning may persist for 1 month, which is why the guidelines typically recommend, even in patients with a lower CHA2DS2-VASc score who are going to be anticoagulated post-cardioversion, that they're on an anticoagulant for at least a month to make sure that their left atrial contractility returns. So, what you don't want to see is this is another TE that was basically obtained in a patient, pre-cardioversion. What you don't want to see is basically the thrombus and then the thrombus leaving, and then unfortunately you have a clean, basically no thrombus by the next image. So for patients who have had AF less than 48 hours, okay, and have a low risk of strokes, they have a low CHA2DS2-VASc score, you can proceed with cardioversion without a TE. Anticoagulation, whether it be heparin initially, Lovenox or novel agent, or no antithrombotic agent, can be considered for a cardioversion, without a need for anticoagulation after the cardioversion, but that's only for patients who have a low risk of stroke. For patients who have, greater than 48 hours or unknown duration, unfortunately, we do see patients who come in, they're short of breath, they may be a little bit volume up, and they really don't know they're in AFib until we tell them. In those patients where we just don't know the duration, your options are to anticoagulate for at least 3 weeks prior to your cardioversion and then 4 weeks after, okay? Or you can anticoagulate and then you can proceed with a transesophageal echocardiogram to evaluate for left atrial appendage thrombus, cardiovert, and then anticoagulate for 4 weeks following the cardioversion. The biggest thing about this is like what I try to explain to the fellows is just because we didn't see a clot at that exact moment that the TE probe was there, without anticoagulation, they could still form a thrombus, okay? So that's why the guidelines are very specific in saying the absence of a left atrial appendage thrombus does not preclude the need for anticoagulation during and after for those higher risk patients. If you do have a left atrial appendage thrombus, we typically will anticoagulate for 4 weeks and then do a relook. And if the thrombus has resolved, which it typically will, we then can proceed with cardioversion. Now, one of the things, one of the reasons why we're going to address anticoagulation before we start an antiarrhythmic drug is because that antiarrhythmic drug may chemically convert the patient, whether it be amiodarone, Ticacin or dofetilide, the class 1Cs, which are flecainide and propafenone, or ibutylide. Starting an antiarrhythmic medication may convert the patient to sinus rhythm. So, unfortunately, it doesn't matter whether you're converting them by shock, converting them by drug, or converting them by ablation. You really want to make sure anticoagulation is addressed, just because you can convert that patient with an antiarrhythmic drug. So, what are the advantages and disadvantages of rhythm control? a lot of what we do for rhythm control is to make people feel better. There are patients who are very symptomatic with AFib. They may have fatigue. They have decreased exercise tolerance. They're just, I've got patients who just feel miserable in AF. The advantage is that you're basically you're getting them back into sinus rhythm. You're getting them to feel better. You're avoiding electrical and anatomical remodeling. You're hopefully preventing the progression of AFib in terms of developing an atrial myopathy with scar tissue. You're basically restoring atrial contractility. And then if you look at recent data that just came out in the New England Journal, you could with an earlier rhythm control approach, you can hopefully reduce thromboembolic events as well as other cardiovascular events by basically getting people into sinus rhythm later. Now there are disadvantages to rhythm control. Unfortunately, as we try to give them an antiarrhythmic, some antiarrhythmics have proarrhythmias. If you look at the older data with the AFFIRM trial, there were patients who, with some of the antiarrhythmics, had an increased mortality. There are people who, unfortunately, the way the antiarrhythmics work is, I could slow them down in sinus rhythm to the point where, I'm either limited with my antiarrhythmic drug dose, or I'm basically prompting them to need a pacemaker so that I can treat their AFib, because most of the antiarrhythmics can lead to sinus node slowing. Okay. Some of the antiarrhythmics do have end-organ toxicity. If we think about, the biggest one that we'll think about is amiodarone. There's other adverse, effects with the antiarrhythmics. And the antiarrhythmics aren't 100%. They may, we expect some recurrences of AF as the AFib progresses, despite the antiarrhythmic. And in some people, we can actually, whether it's due to the rate control effect, you actually can, make AF appear silent or asymptomatic just from the antiarrhythmic effect. So, a lot of what I do when I'm seeing patients for AF is to decide what's, is an antiarrhythmic drug needed? Has their AFib progressed to the point, in terms of, is their burden of AF, is their frequency, is the duration of their episodes progressing to the point where they need an antiarrhythmic? And then the biggest question is which one? And a lot of that comes down to safety. We'll look at their comorbidities. Do they have any coronary artery disease? Do they have LVH? What's their GFR? What's their EF? Because a lot of that kind of, what's their baseline EKG looks like in terms of their sinus rate, what's their QT, because a lot of times it becomes in a lot of patients, it becomes a process of elimination of, the only antiarrhythmic that we can really safely offer is this particular drug based on all of their comorbidities and their baseline EKG. We'll also look at efficacy. Of course, we'll look at cost. Most of the antiarrhythmics are generic. There are some that are brand name, and are more expensive. When we look at, basically, when we're trying to look at the decision tree for what antiarrhythmic, a lot of that comes down to, do they have a structurally normal heart, or do they have CAD or heart failure? If they have a structurally normal heart, then any of the antiarrhythmics can be an option as long as their QT is appropriate. They're not profoundly bradycardic. Typically these are the first line antiarrhythmics that will start. Whether it's one of the class C's, which is flecainide or propafenone, sotalol, or Ticasine, and then as their AFib progresses, if the AFib's overcoming sotalol, for example, then the next step is either amiodarone or an ablation. In patients with structural heart disease, if they have CAD, we unfortunately cannot use the class 1Cs of propafenone and flecainide. So by guidelines, you're already looking at Ticasine, Multac, or sotalol. If their AFib progresses, you're back to either amiodarone or to a catheter ablation. In patients with heart failure, your only two options are amiodarone and Ticasine. So a lot of it comes down to, we'll look at their baseline EKG, we'll look at their EF, we'll look at their GFR, and basically decide what is going to be the best and the safest antiarrhythmic, for that patient. So the goal of antiarrhythmic therapy is we're trying to decrease the frequency, the duration of episodes, decrease the severity. But unfortunately, since AFib is progressive, it's probably not realistic to say that we're going to abolish every episode. The biggest thing is safety, basically, and we're also trying to minimize the risk of proarrhythmia. So as patients AF progress, and unfortunately, and whether they're overcoming medical therapy and in some patients antiarrhythmic therapy, the next step is AF ablation. So AF ablation is indicated for patients who are failing, antiarrhythmic drug therapy, or at higher volume centers, patients who are failing first-line medical therapy, for example, metoprolol or diltiazem. We're a high volume center here. A lot of us do a couple of AFibs a week. So in patients who are failing metoprolol, and there's clearly a benefit of ablating AFib earlier, we'll take somebody to ablation who's having recurrent AFib despite metoprolol, just because our success rates are higher the earlier we can kind of perform the ablation. Some recent data has shown the benefit in patients with heart failure with reduced EF. There's a mortality benefit with maintaining sinus rhythm as well as decreasing CHF hospitalizations. A lot of patients will ask, what's the success rate, and that's kind of a it's kind of a moving target, because the outcome really vary by the center, they vary by the operator, they vary by the technique in terms of the type of ablation that person's using, the lesion set that the person is performing, but it also really comes down to the type of AF. Patients who have paroxysmal AF are going to have a much higher success rate than some of the persistent. And part of that is due to the atrial myopathy that develops, as the AFib progresses. So for the most part, whether your patient is persistent or paroxysmal, the vast majority of the ablation is very similar. As the AFib progresses, we'll do a lot of, we'll do more substrate modification, but unfortunately, those patients are just going to have a lower success rate due to the atrial myopathy and the scar tissue that can develop with longer durations of AF. So a lot of patients who are persistent, I'm like, I can tell you, most of my persistent patients, will require a second procedure, just due to the amount of substrate that may have to be modified and cleaned up due to the progressive nature of their AFib. A big thing is it does not eliminate the need for anticoagulation. We're not ablating people to get them off of their anticoagulants, okay? We're really ablating them to get them to basically to feel better, or to, if we have patients who go into AFib and they have their heart failure exacerbations, if we keep them in sinus rhythm, we're going to reduce their, CHF hospitalizations. The biggest thing with AF ablation, if you're thinking about sending a patient, is you're thinking about it, just send them. The earlier that we can get to them, the success rates and the outcomes are just so much better. When we look at how AFib originates, it typically originates from ectopy that originate from the pulmonary veins. So this is like basically intracardiac tracing, and there's a lot of squiggles, and people are, I'm sure, going to sleep immediately as we look at this. But what we have is a person in sinus rhythm. So they're in sinus rhythm. If we look at their surface lead, we have a P wave and then sinus rhythm. We have a catheter in one of the pulmonary veins. That pulmonary vein fires, and an earlier PAC fires, and then it drives the person into AF. So just that one fire, that early PAC firing from that one area of that pulmonary vein, is enough to trigger someone into AF. They have a short burst of AF, and then they spontaneously, convert back into sinus rhythm. So AF ablation is really, the other term that we'll use for it is pulmonary vein isolation. So what I'm trying to do is kind of electrically disconnect the pulmonary veins from the atrium. So the pulmonary vein, will still try to fire, but in an electrical wall, so that it can't get into the left atrial proper to stir up AFib. So what we're really trying to do is and this is, for one of my patients from a recent ablation, I build an electrical map. The left atrium is electrical. I measure voltage throughout the left atrium, and then, I look for any areas of scar, fibrosis, that prior episodes of AFib that have kind of led to that part of their atrial myopathy. And then I look for the connections between the pulmonary veins and left atrium, and then I proceed with ablation. And what I'm doing is kind of a dot by dot, to basically form an electrical wall so that once I've completely encircled the pulmonary veins, what we can do is then I have a catheter in the pulmonary vein. I want to make sure that no electricity is getting across into the left atrium. And what we'll commonly see is we'll have a catheter in one of the pulmonary veins. That pulmonary vein will still fire. It'll still fire PACs, it'll still fire atrial runs, but what we'll see is that electrically it's dissociated from the left atrium, and it basically that electricity just can't get in to conduct and stir up AFib. So the other term that you'll sometimes see for an AF ablation is pulmonary vein isolation, and the bulk of an AFib ablation is pulmonary vein isolation. In patients who have persistent AF, we'll look for other areas of scar or fibrosis that's developed, and we'll do some substrate modification for that. But the bulk of the ablation is really pulmonary vein isolation. There's a lot of good data that in addition to antiarrhythmic drugs, ablation, that with AF, we really have to take basically a system approach to treat AF, okay? And what the guidelines refer to is what's considered upstream therapy. We need to somehow, through medical therapy and treatment of other comorbidities, we need to modify the atrial substrate to reduce susceptibility and progression of AF to kind of prevent that atrial myopathy. So in patients who have heart failure and hypertension and also have AF, an ACE inhibitor and ARB is reasonable for primary prevention of new onset AF in those patients. In patients who, have, basically new onset AF after CABG, statin therapy from its anti-inflammatory effect is reasonable for primary prevention in those patients as well. There's very good data that, that sustained long-term weight loss is associated with a significant reduction in AF burden as well as maintenance of sinus rhythm. So unfortunately, like I tell patients, we can, I can put you on sotalol, we can do an ablation, but weight loss will also help your AF as well. We clearly see an association of obstructive sleep apnea and AF. Basically we see a lot more AF in patients who have sleep apnea. We basically, we'll refer them for sleep studies. We'll, basically refer to them. We'll talk to them about compliance with their CPAP. Because it really does take a systems approach to manage people's AF now. So, rate control, what we're trying to do with rate control, we're going to shift gears a little bit and just talk about rate control, is, a lot of times with rate control, people are in AF and we're just trying to control their heart rate. So we're going to use beta blockers and calcium channel blockers, and we're trying to control their resting and exercise heart rates. I personally don't use a lot of digoxin because digoxin really will just kind of control the resting heart rate. It's really not going to give you exertional rate control, which is just very important. The biggest thing with rate control is we're trying to reduce symptoms and avoid tachycardia-induced cardiomyopathy. I commonly see patients who, are not aware of their AFib. They don't have palpitations. They don't have that awareness of their heart. They're not aware they're in AFib until they get up and exert. Okay. And it's really heart rate related. They're basically going 150, 160 with minimal exertion. That's when they're symptomatic. You get them under rate control their heart rate, and their symptoms, their exertional dyspnea, their exercise tolerance gets a lot better. So, we're basically a lot of times we're using beta blockers and calcium channel blockers. What we're trying to do in patients who are symptomatic is get their resting heart rate typically less than 80. Okay. There's been studies looking, like, for example, RACE-2, looking at, do you need a very strict rate control, or can you be more lenient? You can have more lenient rate control in patients who are asymptomatic, but their LV systolic function is normal. Okay. In the RACE-2, there really wasn't, a significant difference in patients who had a lenient rate control versus a strict rate control. But the biggest thing is those, we will take that approach in patients provided they're asymptomatic and provided that their LV systolic function remains preserved. A lot of times in critically ill patients, we'll have to use IV amiodarone for rate control. there's always that risk that you may convert the patient, but in patients who are critically ill, who are hypotensive, who are having AFib with RVR, provided they don't have pre-excitation, IV amiodarone is useful for rate control. You may inadvertently convert the patient. With regards to digoxin, like we talked about, it reduces resting heart rate. It can be combined with a beta blocker in patients with CHF. In the AFFIRM trial, there was an increased mortality in patients who were on digoxin, but a lot of that was patients who had a higher serum dig level, at least what we saw in the dig trial. So for people who either have AFib and are asymptomatic with it, but we cannot get them under reasonable heart rate control, or patients who have AFib with RVR, we're having a lot of difficulty rate controlling them. And for example, I have patients who just don't have enough blood pressure to tolerate all the metoprolol they need to slow down their AFib. There is a role for what we call Ablate and Pace. So they undergo pacemaker implantation, and we then basically ablate the AV node. What we're trying to do is really a junction ablation. So I'm trying to ablate high enough on the AV node so that we have complete AV block, but that they have a slower junctional escape under that, but they just don't see it because the pacemaker is setting the rhythm. So, for someone with a normal EF, they'll, undergo implantation of a single ventricular lead, and then we proceed with an AV nodal ablation. A lot of patients do very well with this. It gives them rate control, but it also regularizes the ventricle. So they feel better just because they're regular, okay, and they have rate control. For patients with heart failure, we typically would implant a biventricular device with an RV and an LV lead. But I have a lot of patients who respond very well to an Ablate and Pace approach, and they do very well. I've had patients who have developed a tachycardia-related cardiomyopathy in the setting of their AFib, just because we just can't achieve a good rate control. We undergo an Ablate and Pace, and their LVF improves just with a combination of rate control and regularization. So that is always an option for patients who or just we're having difficulty controlling, achieving an adequate rate control. So to kind of wrap things up, AFib, it's the most common arrhythmia. Management of AFib at times can be very complex depending upon the patient. Unfortunately, we're going to be seeing more of it just as the population ages. One thing to think about is, one thing is we need to really talk about their risk of stroke, their risk of bleeding when we talk about anticoagulation. Based on the recent update, the novel agents are preferred over Coumadin. If you have patients who can't be anticoagulated, but do have a high risk of stroke, there is the Watchman device, which is basically a closure device for the left atrial appendage. When it comes to, either rate control or rhythm control, that's kind of the two arms of how we're going to address the actual rhythm itself. With rhythm control, a lot of that involves antiarrhythmic drugs and ablation. For patients who are asymptomatic with AFib, or for example, who have permanent AFib, where we just can't get them back into sinus rhythm, and we take a rate control approach, we're going to use beta blockers, calcium channel blockers to achieve rate control. And for those patients who either we can't achieve adequate rate control or who are still symptomatic, Ablate and Pace, is an option for those patients as well. So I thank you for your attention. I'd be happy to entertain any questions, either by email. My email, if you'll just give me a day to respond, I'm happy to entertain any questions. Or if you have any patients you need help with, email. There's my email, my contact information. So I thank you for your time.